Good day. Our topic for today is the thyroid gland. Let's lay down our objectives. First, to revisit the historical background of thyroid, to review thyroid anatomy and physiology, to know the different laboratory and ancillary procedures and their applications in thyroid evaluation, and to learn the commonly encountered thyroid diseases, both benign and malignant, and study their clinical features. Let's go back to the historical background. Goiter, from the word gutor, means throat, and thyroides means shield shape. Goiter is the enlargement of the thyroid. It has been recognized way back since 2700 BC. In 1170, Forgardi has the first account of thyroid surgery to treat goiter. But take note, he has a mortality of up to 40%. These two prominent people are the one most notable for thyroid surgery. These are Cocker and Billroth. They perform thousands of operations with increasing success as they gather more number. After total thyroidectomy, patients, especially children, becomes myxedematous and cretinous. Cretinous features are noted. They are known as the myxedema. Felix Simon noted that myxedema is secondary to the loss of thyroid function. It is in 1891 that George Murray first effectively treated myxedema with subcutaneous injection of extract of sheep thyroid. But Edward Fox demonstrated that even oral therapy is equally effective. Then William Halsted noted that the outcome of the surgery is where this myxedema has originated. He is the first surgeon that suggests that outcomes were dependent upon the operative technique. So let's take a look at these first two surgeons, Cocker and Billroth. Cocker is extremely neat and precise, operating slowly and often removing the entire thyroid. But patient develop myxedema because no thyroid is left. But he rarely suffers from laryngeal nerve injury or post-operative tetany. While Billroth, he works rapidly, he often removes the parathyroid but left more thyroid tissue behind. Patient had significant post-operative hypoparathyroidism but rarely developed myxedema. Enough for the historical background. Now let's go to the anatomy of the thyroid. Thyroid gland weighs approximately 15 to 20 grams. It is located behind the strap muscles. The isthmus, as we can see here, connects the two lobes, the left and the right. Pyramidal lobe is the remnant of the caudal end of the thyroglossal ductus. Not everyone has pyramidal lobe. What are the strap muscles of the thyroid? We have the sternohyoid, sternothyroid, and the superior belly of the omohyoid, all innervated by the ansa cervicalis. There is a varus ligament, posterior suspensory ligament, attaching the posterior thyroid to the upper tracheal ring. Let's go to the blood supply. Thyroid has the superior thyroid artery, the inferior thyroid artery, and in 1 to 4% there is the thyroidea. Drainage the thyroid is being drained by the superior thyroid vein, the middle thyroid vein, and the inferior thyroid vein. Take note, there is a middle thyroid vein but there are no middle thyroid artery. When it comes to recurrent laryngeal nerve, the left one goes through the arc of the aorta and loops going up back to the thyroid, while the right recurrent laryngeal nerve loops around the subclavian artery before ascending back to the neck. Recurrent laryngeal nerves in relation to the parathyroid, the lower parathyroid is anterior and the upper parathyroid is posterior to it. These are pictures of recurrent laryngeal nerve injury. Recurrent laryngeal nerve innervates the intrinsic muscles of the larynx. As mentioned earlier, But cricothyroid muscle is innervated by the external laryngeal nerve. Recurrent laryngeal nerve injury when unilateral may paralyze the ipsilateral cord, vocal cord, which can lie in the paramedian or an abducted position. Thus, hoarseness or ineffective incupping occur. But if a surgeon injures both the left and the right, this may lead to airway obstruction and loss of voice. The superior laryngeal nerve goes alongside the internal carotid artery. At the level of the hide bone, it gives two branches, the internal branch and the external branch. The internal branch is the sensory to the supraglottic larynx. Injury to it results in aspiration. External branch, on the other hand, descends alongside superior thyroid vessel before innervating the cricothyroid muscles. So, superior laryngeal nerve innervates the cricothyroid muscles, and injury to it gives the inability to reach the high notes. So, the review of anatomy, we have the laryngeal nerve, recurrent laryngeal nerve. We have the artery, the vein, and the structures associated with the thyroid. The triangle of the neck, way back from your anatomy days, has been studied. Up to your practice, this will be a very important information, so take note of it. Review the different triangles of the neck and the lymph nodes located to them. I will give that to you as your review assignment. Now let's go to histology. Thyroid is divided into lobules containing 20 to 40 follicles. Each follicle is lined by cuboidal epithelial cells and contains a central store of colloid. In this picture, this is the colloid. Those are the cuboidal cells. Parafollicular cells, such as this one, contains and secretes calcitonin. Reviewing the physiology, hypothalamus secretes thyroid-releasing hormone to the pituitary gland. The pituitary gland will release thyroid-stimulating hormone, which stimulates the thyroid, and the thyroid will secrete thyroxine. Going to the thyroid hormone synthesis, we have iodine trapping, oxidation, iodinization of thyroxine residues, and then the coupling. Thyroglobulin then is hydrolyzed to T3 and T4, and then the deionization process. Let's go to the ancillary and laboratory procedures. TSH is the most important, take note, the most important test for euthyroid patient. In hypothyroidism, it is elevated. In hyperthyroidism, it is suppressed. It is the most sensitive and specific test for the diagnosis of hypo and hyperthyroidism. Total T4 and total T3 reflects the output of the thyroid gland. T4 reflects the output, elevates by hyperthyroid states and in conditions such as pregnancy and the use of estrogen and progesterone. Total T3 is used in clinical hyperthyroid patient with normal T4. They might be normal because they have T3 thyrotoxicity. Free T4 and free T3 are sensitive and accurate in measuring the biologically active thyroid hormone. They are not used in screening. They are used in free T4 is used in early hyperthyroidism, while free T3 is used in diagnosing early hyperthyroidism. TRH elevate pituitary TSH secretion function, and thyroid antibodies are used for autoimmune thyroiditis such as the Hashimoto's and the Riedel's thyroiditis. Thyroglobulin is very important, especially after surgery for those malignant, well-differentiated malignancies. It increased dramatically in destructive process of thyroid gland. It is used in monitoring patients with differentiated thyroid CA for recurrence, especially after total thyroidectomy. Now let's go to the thyroid imaging. RAI or radionuclide imaging, there are two types, the 123 and 131. They have different half-lives and they have different usage. 123 is to image lingual thyroid and goiters, those active thyroid for evaluation, and 131 is used to screen and treat patient, especially the differentiated thyroid CA for metastatic diseases. Ultrasound is one of those most useful ancillary procedures. It is non-invasive. It can distinguish solid and cystic. It will identify the size and the multicentricity of those nodules. And most importantly, it assesses cervical lymphadenopathy. Take note, the most important function of ultrasound is to assess the cervical lymphadenopathy. It is also used as a guide for fine needle aspiration of the thyroid nodules, especially those non-palpable nodules. CT scan and MRI may be used in evaluating the extent and the fixation of the thyroid and their relationship with the other structures surrounding the thyroid. Now let's pause for a while before we go to the thyroid diseases.